So this is an annual series in which the association goes out to communities to discuss public policy issues that affect people with Alzheimer's and other dementias and those who care for them. My name is MJ McDermott. I'm the morning meteorologist at Q13. And I'm proud to say that it's sunny out today. And I hope you're enjoying. Yeah, what's that?
Are you sure?
Yeah, well, let's see. Yes, it's my professional view. Sunny. Yeah, we've had a warmer than normal and drier than normal November so far. So hopefully it won't be too bad for people on the Thanksgiving holiday making it over the mountains from Washington State for the Apple Cup. Go Dogs. It's funny because I just shot a promo for the Apple Cup. It's going to be on Q13. And I wore purple because I did go to the University of Washington. I went, perfect, it's the color of the Alzheimer's Association. But I also have a personal relationship to the disease. My mother died a year ago at 92 and of complications due to Alzheimer's. And I'm not sure how long she was sick with it because it's that whole beginning of it where you go, what is wrong? What is going on? Is she just being volitional? Is she just having some memory issues? And I finally saw a doctor give her, I think it's the Montreal Cognitive Assessment, and the thing that got me was watching her try to draw the face of a clock. How simple is that? And it was like, holy cow, my mom can't draw the face of a clock. How long has this been going on? And she would giggle a lot to kind of hide all the stuff that was happening. So it may have been 10 years, it may have actually been 12 years, a very slow decline that just, frankly, was challenging for, let's just say, all the family caregivers involved. Also, my mom was one of 10 children, 7 of whom survived to adulthood, and 5 of those had dementia of some kind by the end. So I'm pretty sure if genetics is any part of this, that I could be on the road to the same thing. So I'm personally invested in the work of the Alzheimer's Association that we lead to, finally, as I've read in the program here, a world without Alzheimer's, because it is such a devastating disease to people who have it, and of course for the caretakers. So we're pleased today to be joined by several staffers in our state's congressional delegation. Representing Senator Patty Murray is her Seattle Metropolitan Director, Kate Baumgardner. Kate? From the office of Senator Maria Cantwell is Casey Duff, her state scheduler and outreach representative. And then joining us later with Marvin Eng is the district representative for Congressman Adam Smith of South Seattle. Congress is a little busy today. Okay, so we appreciate your active interest in the work of the chapter and Alzheimer's priorities in Congress, of course. Are there any elected officials, others, or staffers here today? Okay, great. So today's major presentation will be given by Jim Wilkes, the regional leader for the Alzheimer's Association in the Pacific Northwest of Alaska, Idaho, Oregon, and Washington, for which he serves as the executive director. Before taking the regional role in 2017, he spent 7 years as a field representative and liaison in the Chapter Relations Division of the Alzheimer's Association's home office in Chicago. By the way, I'm at the tail end of a cold. I apologize for the gravelly voice. I'm just going to call it sexy. Okay. Being the key connector to over 50 of the 80 chapters in our network. Jim started his career in the voluntary health industry in 1988. What is the voluntary health industry?
It's the collection of organizations that are nonprofit health organizations that are largely driven by volunteers. So American Heart Association, American Cancer Society, American Diabetes Association.
I just want to give applause to voluntary health industry. In 1988, shortly after graduating with a degree in public relations from Butler University in Indianapolis. He did a 20-year stint with the American Heart Association, serving in leadership roles in 6 states in the Midwest and the South, and eventually a 10-state territory based out of Seattle. He also served as the president and CEO of the American Lung Association of California. Jim has 3 adult sons, 2 who live in the Seattle area. And the core of his motivation in Alzheimer's leadership is not only professional, but personal, as he, as a long-distance caregiver, lost his grandmother to the disease in 2017 after a long and heartbreaking 8-year path with the disease. He sees the next phase of career as pursuing the work his grandmother would want him to pursue, to make a world without Alzheimer's for his children, grandchildren, and eventual great-grandchildren. Please welcome Jim Wilgus.
Thank you very much. Appreciate that. I wear purple because I'm committed to the mission of the Alzheimer's Association. I also wear red because I'm a Cougar fan. Look forward to the Apple Cup on the 29th. Actually, two of my sons went to WSU, so I didn't go. I went to another, as was mentioned, Butler University in Indianapolis, but a lot of my money went to WSU, and still is. So, thank you all for being here, particularly those from the elected officials' offices. Appreciate your time. We're running a little behind, but I think we'll be able to stay on time and honor the 2:30 close. So we're going to go through a variety of... So what we want you to leave with is understanding what our federal priorities are in public policy, what our state priorities are, and also a little bit about the disease and some of the numbers and numerics. I had one page that got out of order, so now I'm at my right page. So the issues that the Alzheimer's Association and the Alzheimer's Impact Movement, our advocacy affiliate, work on in Congress are intended to carry out the priorities established by the National Alzheimer's Plan. This plan was written in early 2011, and it sets the national goal of having a treatment, a therapy, a cure preventing Alzheimer's disease by the year 2025. That was a goal established by the United States government along with the other governments in the G7 that by 2025, over the course of about a 10-year period of time when that goal was set, that we would see that therapy, that cure, that treatment, as Alzheimer's disease is not only a United States issue, it's a worldwide issue and epidemic. So the logo of the Alzheimer's Association, if you can kind of see at the lower level, it really embodies our twin mission. The left side is the head. It stands for an individual, caregivers, people living with the disease, people that we as the Alzheimer's Association want to provide services for and help. On the right side is a beaker, and that signifies the research aims and angle of the organization. So we're caring both for people with the disease and those caregivers. We're also striving for eventually a world without Alzheimer's disease via research and science. In the early 2010 timeframe, scientists said it would take $2 billion in research funding was needed to each year go in to meet the science goals. And the professional judgment budget gives us a plan and a dollar request that the scientists at the NIH indicate annually, this is what we need in revenue and funding to accomplish the goals toward that 2025 goal of, again, a scientific breakthrough, a therapy, a treatment. At the time, Congress was appropriating less than $500,000. So it was a steep cliff to climb. Our advocates in the Alzheimer's Association repeatedly have gone to Congress annually to advocate for increases in research funding, along with other issues as well. But what happened was Congress enacted a law, the passage of the Alzheimer's Accountability Act. This law requires that scientists at the NIH to give directly to Congress a proposed budget each year, spelling out exactly what they need. We're gratified that Congress approved these appropriations, and they figure each year in the annual budget that goes straight to Congress from the NIH. So in our chapter territory, which if you look at the map over there, includes the state of Washington and also northern Idaho, listed are the senators and members of Congress who are supportive and have been very supportive of these increases, including Senator Patty Murray. Also Representatives Herrera Butler, Kilmer, Newhouse, and Simpson, who are also on the Appropriations Committee and annually move these dollars through. Now to illustrate this, when I began the organization in 2010, as I mentioned earlier, we were less than $500 million in research funding, and just barely ticked up above it in 2012, 13, etc. Now, if you won a Powerball lottery, $500,000 is a lot of money to any one individual. But in a disease space as large as Alzheimer's disease, it was very insignificant in comparison to other disease spaces. Around $6 billion for cancer, around $4 billion for heart disease, around $3 billion for HIV/AIDS. We were at less than $500 million. But through the efforts of advocates, volunteers, members of, like many of you, who repeatedly contact their members of Congress, write a letter, go to Washington, D.C. and advocate. By 2015, they began to hear our message around the significance of getting that amount to above $2 billion, and we accomplished that. No other disease has had these kinds of increases in research funding in the last, really, 25 years since the onset of the HIV/AIDS epidemic, where you really began to see monies toward that disease uplift. But these are outstanding levels of increases, and this gets put it into the base. So basically, once the monies are there, they're there annually, and we continue to advocate for more. So since 2015, we basically have quadrupled the amount of monies that go into Alzheimer's and dementia research, and this is what's going to eventually help us to identify that solution. So what's the progress that's been made through the NIH investment? You know, what have we seen thus far? Essentially, we have a better understanding of genetic risk factors that cause the disease. We're revealing disease mechanisms. We're creating better biomarkers to better detect and diagnose the disease. We're accelerating drug design and human testing. In fact, there's 3 very promising opportunities that are just around the corner that may potentially be going to FDA for approval on 3 different drugs, so that we might, even as early as 2021, see a potential of one of those coming out to market. We're testing treatments, making clinical trials more efficient and inclusive, and we're intensifying research on care and services. So what's the progress toward a more effective treatment? A future Alzheimer's treatment or therapy is probably going to be a multifaceted composite of activities and lifestyle behaviors. You know, when I started in 2010, folks would say to me, when are we going to come up with that drug that's going to prevent, that's going to slow down the progression of Alzheimer's disease? And what we're learning is definitely, you know, pharmaceuticals and other organizations are looking for that next drug to go to market. The first one would be to market since 2003. But we're learning that lifestyle interventions are often going to play a role in how living with or preventing Alzheimer's disease or dementia is going to be a part of that. So what's being said now more and more is what's good for the heart is good for the brain. So healthy sleeping, exercise, lowering blood pressure, having good nutrition, a mixture of all those lifestyle behaviors is going to have to work probably hand in hand with any potential future therapies, drugs, or treatments. So a lot of this has recently reached the news. We host annually the largest assembly of individuals who come together from the science community along with the media called Alzheimer's Association International Conference. And that oftentimes spurs quite a bit of news that comes out around the progress of science impacting in a positive way, or even in a way that takes us in a different course related to the disease. And most recently, the Sprint Mind study was one that came out at our conference in 2018. And it was a study that was done related to a clinical trial where individuals who kept their blood pressure below a certain level, the hypothesis was that would those individuals have a slower progression of mild cognitive impairment or dementia compared to individuals that took a placebo. That study was aborted 2 years early because the findings were so dramatically significant that the connection between keeping blood pressure below 120 and that being a potential factor of slowing the disease, it was so significant that that it caused us to have all these kinds of different media reports. So what's important about this study is that investigators were allowed to use blood pressure medications and advocate for changes in diet or exercise to control blood pressure. So this was very significant and important. So why is this important? And this, again, points to the fact that multiple interventions of lifestyle changes could potentially increase the individual's ability to decrease onset of dementia or other risk factors. So, immediate opportunity with life-changing impact potential. So, the U.S. study to detect brain health through lifestyle intervention and reduce risk is a study that we're actually doing, and this is something that the Alzheimer's Association not only funds scientific research, where we have meritorious grants that are submitted for potential for funding, and then we fund them at universities or other education settings throughout the country. But we also fund some of our own research studies, and the U.S. Pointer study is one of those. So it was taken off of a study that was done in Finland called the Finger Study. And it was a study in Finland where they were able to see with lifestyle interventions a dramatically reduced onset of dementia or mild cognitive impairment. And what's interesting about Finland is that it's a very low in-migration, low out-migration country. So most of the people who live there have lived there for generations, families that have lived there for several hundred years. So the composite of individuals, it's a very stable test group, if you will. But our Pointer study is a 2-year multi-center randomized clinical trial. It's self-guided and structured lifestyle groups. And there are 2,000 participants at 5 U.S. sites throughout the country that are currently being recruited for this study. So, kind of talking about why all this is important. If we don't change the trajectory of the growth of the disease, we could be facing a crisis in our country financially by 2050. So if we develop a treatment by 2025 that delays the onset of Alzheimer's by just 5 years, then only 5.7 million people would be expected to develop Alzheimer's disease by 2050. Aside from that, if we don't find a way to delay this, that number goes dramatically up, closer to 15 million and close to 50 million worldwide. So that's the issue, is finding a way to slow the disease so we can dramatically decrease the number of people that are living with the disease by 2050 and don't have costs for Medicare that could exceed $1 trillion, which again would be financially perilous to our country. So our federal appropriations priorities for this year are to continue those increases in research funding by $350 million. That would get it to about that $2.8 billion figure that you saw in that final bar on the previous slide. And our current supporters for that are Senators Marion Cantwell, Crapo and Risch from Idaho. Again, Idaho is a part of our territory, so we collectively advocate to those individuals from that state. Representatives Del Benny, Jayapal, Larson, Schreier, Garrett Butler, Newhouse, and Kilmer. So again, if any of those members of Congress are your elected official, please thank them. But also to give to the CDC $20 million to implement the new Bold Infrastructure for Alzheimer's Act, supported by Senators Cantwell, Crapo, and Risch. And I'll talk a little bit about the Bold Act and what that's intended to do. The Bold Act was passed as law, but now we're going to go back to get the funding to implement the actual act itself. So what is the Bold Act? We're asking for the $20 million to implement the new law, passed in 2018. The CDC is going to set up centers of excellence to look at the best techniques for care and support. So identifying hospitals, facilities, health systems that adopt best practices and standards in dementia care, and then lifting them up as examples to other locations throughout the country, and then funding those centers of excellence so they can continue to be cutting-edge trendsetters in the best practices of dementia and Alzheimer's care. It's also to drive state and local health departments grants to implement programs that they can then use those techniques, emphasizing early diagnosis, avoidance of hospitalization, encouragement of social engagement activities in communities, helping communities to be dementia-friendly. So these dollars are going to be driven into applying health, local municipal health departments to, again, pursue these best practices at the community level. And also to document effectiveness so that we're learning from, again, these best practices and where they're being applied and successful in communities. So the Improving Hope Act, one of the things that this also would do is, right now only 1% of seniors living with Alzheimer's disease got a Medicare care planning session during their annual wellness visit in 2017. Even though we recently had Medicare come up with an existing code that healthcare professionals can be reimbursed for when they provide a 1-hour care planning session to an individual that's been diagnosed with the disease. So this would help to promote that benefit, and we also want to report on barriers on how the usage can go up and any barriers that prevent medical professionals from implementing that care planning benefit. So thus far, this has been co-sponsored by the representatives you see listed here, along with Senator Crapo from Idaho, and certainly if any of these members of Congress are one of yours, certainly thank them for their co-sponsorship of this act. The final priority that we're pursuing is the Younger Onset Alzheimer's Disease Act. So annually, well not annually, but every 5 to 7 years, the Older Americans Act, the Americans with Disabilities Act, they get put up to Congress for reauthorization to see, in this case, the Older Americans Act that was instituted during the Johnson administration in 1965 is what's in there today relevant for where we are as a country in 2019. And this would be the act that provides for communities things like Meals on Wheels and transportation services. Our issue is that the Older Americans Act is you're only eligible when you're 65 or older. Yet we know that there's 200,000 individuals in the country today living with Alzheimer's disease with a diagnosis that are not eligible for those benefits that can provide them services in the home or in their community. So the new legislation would allow people younger than 60 who've been diagnosed with a dementia diagnosis or Alzheimer's disease to receive these key Older Americans Act services. It also would include the funding to support the addition of those individuals in that program. And currently it's supported by the senators and the members of Congress you see listed here. So what about the disease in our state? So in Washington, Alzheimer's disease is the 3rd leading cause of death behind heart disease and cancer. Currently, there are 110,000 people living with Alzheimer's disease. And by 2040, unless we change the trajectory of the disease, that number is expected to increase to 270,000. And currently, there's just under 350,000 unpaid caregivers here in Washington State. Individuals who are family members, who are neighbors, who aren't being paid and productively are being taken out of their own profession in communities supporting individuals with the disease, delivering just under 400 million hours of care worth $5 billion. So it's an issue, and the problem facing Washington is that half of the individuals who have reported that they have memory loss issues or that that's getting worse have not talked to a healthcare professional. This fact was revealed by the authoritative BRFSS public health survey done by the state health department. Fewer than half those people who were so impaired that they met the critical criteria for dementia actually received the diagnosis. So far too many individuals in Washington and in every state in the country are being underdiagnosed or not diagnosed with memory issues or with the disease, therefore not able to take effective steps for planning and for care and support. So, but of those who were told their diagnosis, fewer than 10% were given a referral to an Alzheimer's Association or another support organization, and just 14% were given information about resources available in their community. I know I can share with my staff the thought that far too many times we run into individuals who say to us, "I wish I knew about you when Mom, Dad, my sister." When too often times people contact the Alzheimer's Association when they're in a complete stage of crisis because the person hasn't received a diagnosis, they themselves haven't received a diagnosis, and then therefore haven't been given the proper care planning or referral to an organization like the Alzheimer's Association. So, as I said, without a diagnosis or post-diagnostic support, patients and families can't get the needed care, and the other issue is that Medicaid payments for dementia are 23 times more expensive than for individuals who don't have dementia or Alzheimer's disease. So diagnosis, increasing that is important. Understanding organizations like the Alzheimer's Association are available for care and support services. And then also, as I mentioned, promotion of that Medicare code so that physicians know I can provide care planning and get reimbursed for that. So in Washington, we have a state plan to address Alzheimer's disease and other dementias. This was created and put into effect January 1 of 2016. And these are the various things that the state plan does. It increases public awareness, it prepares communities, it ensures well-being and safety, promotes innovation and research, and long-term care and supporting services, etc. So the Dementia Action Collaborative, or I'll refer to it as the DAC, an acronym, DAC, is a private and public partnership of organizations like the Alzheimer's Association, like the Department, DSHS, HCA, the Department of Health, other Alzheimer's support organizations that we are an allied partnership and support with, medical providers, family caregivers, individuals with the disease. There's 68 stakeholders, myself being one of them, who are a part of this collaborative. And there's many subcommittee members and project team members that operate on a year-round basis as the people body, if you will, to carry out the implementation of the state plan here in the state of Washington. Here's what was accomplished as a result of the state plan being put into force. We now have a dementia roadmap. I believe there's copies here on the table. 140,000 copies of those were made and are being distributed. We have a safety toolkit. We operate a dementia-friendly community toolkit, so communities can identify ways that they can be more dementia-capable and friendly. We have information for Asian Americans, African Americans, and then we have a point-of-access website with the www.memorylossinfowa.org that's available to the public. Our priorities for 2019, we won $1 million in funding from the state of Washington legislature to begin to implement recommendations in the Alzheimer's state plan. You'll see the three areas that we received funding for. It is to increase physician education through Project ECHO, which is like a telemed kind of a care and support network program for physicians, particularly benefiting those physicians in more isolated rural areas. A public education campaign, which will be aimed at reducing stigma of the disease, and then pro bono help for elder law attorneys to assist them in understanding ways that they can help clients who are facing dementia or diagnosis in their financial and other kinds of care planning. So that's what was funded. These are the items related to that were funded in 2019, including the UW telemedicine program for providers and content experts, which helps them to better network with dementia care experts, again, via Project ECHO and telemedicine. So, also funded, again, was the public awareness campaign, again, aimed at reducing issues with stigma, promoting normal aging, the warning signs of dementia, and value of early diagnosis, and again, that legal and care planning. So our priorities for 2020. So we went to legislature for 4 priorities, and we got the 3 cheapest ones funded. So now we're going to go back and get advocate for getting the 4th one funded, which is essentially around $1 million that will help us to provide community-based embedded professionals in 4 areas of the state. And this would be in partnership with our area agencies on aging. And this would have
this opportunity to talk here today. And I'll start with a disclaimer. I am no expert at Alzheimer's, but I certainly do want to talk about my family's experience with this disease. My father was a retired Air Force officer, and most of his life he was in pretty good health until one day when he was 80 years old, he suffered a heart attack, and that required an emergency bypass surgery. The surgery was successful, but when he came home from the hospital, we noticed that he had significant memory changes. And thus began his 7-year journey with dementia. He passed away about 3 years ago. We lived next door to my parents, so I became his primary caregiver with help from my brothers. Both of them lived out of state. And being a physician, I had some knowledge of dementia and Alzheimer's, but I quickly learned while taking care of my father that is so much more than just memory change. It affected every aspect of his life. Simple things like taking a shower and self-care became a huge challenge. And providing care for dementia patients is made so much harder because a lot of time he would refuse help because they don't understand why they need it. Towards the last years of my father's life, he did not remember our names or how we were related to him. But I honestly felt that was the less often distressing part of the ordeal, because a lot of people with dementia and Alzheimer's, for want of a better word, have a personality change, and so somebody who's been very soft-spoken and gentle the entire life may become extremely paranoid and even become disruptive. And that is honestly one of the hardest things for families to deal with. My father's physician was a geriatric specialist, and so that's a doctor who takes care of older individuals. But unfortunately, he wasn't able to help us much, even with his dementia-related issues. My father stayed at home till the very end, and when we were not at home, we made sure that one of the paid caregivers were there 24/7. In the end, my father passed away from congestive heart failure. He was still able to walk and he was still able to feed himself till the end, but I know many people with dementia who actually forget to even do that. So if I was to pick one word for our experience with dementia and with Alzheimer's disease, I would say it was overwhelming. But I know that my family's experience with this disease is not unique. As we've talked about it, more than 100,000 people in Washington state suffer from this disease, and more than 5 million in the United States do. And as we had said that, I think this number is an underestimate because so many people remain undiagnosed. And as we have said, here before, that I think that as with any disease, the ultimate goal is to find a cure for this disease. But until that happens, I think we need public policy changes and we need better physician training so that we can provide improved care for individuals with dementia and their caregivers. And we have talked about the dementia roadmap, and I wish we had something similar to that when we were taking care of my father, because it definitely gives you a guideline and it gives you some idea of what to expect and how to deal with some of these issues. I'm really thrilled that the research money for Alzheimer's at NIH has increased many folds in the last few years, and I'm really hopeful that we will have a treatment available for this disease, and I'm hoping very soon. Thank you.
Thank you so much. I feel like one of those people, and Jim said, I wish I'd known about the Alzheimer's Association earlier when my mom was first diagnosed. I had no idea what was going on. And I'm most encouraged, really, of all the things you've discussed, the concept of more training for primary care doctors. Because I honestly watched my mother shamed by her doctor. I'll never forget, I was sitting, my mom was facing me and their doctor was behind my mom, And my mom was having severe anxiety attacks and calling 911 thinking she had a heart attack. And her doctor said to me like this, "It's costing too much money." And then she looked at my mom and said, "I talked to the head of psychiatry. If this happens again, we're going to commit you to the Geropsychiatric Center." And behind her head, my mom, she went to me like this, "We don't want that. It's the loony bin." And I was just like, what the F? I had no idea where to go. And, but thank goodness I got hooked in with some good people at the Geropsychiatric Center at Northwest Hospital. I was stunned to find some resources there, but she had no idea, my mom's doctor, what was going on, and was only concerned with how much money it was costing, because my mom's, anyway, and my grandmother also, and we just called it senile at that point. You know, no one knew anything about it when my grandmother died in 1980, so it is encouraging. There have been, you know, improvements made, but there's still a lot to be done. So thank you for speaking today. Does anyone have any questions for someone on our panel right now? Here, and they will also stay late to answer questions one-on-one, yes?
Oh, sure.
Okay.
I just have one question. Why did they take so long to figure it out that what they were working on to cure this wasn't working? I mean, it seemed like they were on it for so many years and never got any improvement. And so it seems like it just, it was a waste of time.
I don't know the specific years,
Yeah.
but Alzheimer's disease was discovered by Alois Alzheimer, a physician from Germany, France?
Germany.
And he discovered post-op at an autopsy in a woman who was about 52 years old, the disease that actually showed the physiological plaques and tangles associated. That research sat on a shelf for at least 60 years without any attention given to it, because it was felt that that was such an isolated, unique situation that would not be replicated. It wasn't until the mid-60s, it was a thing around the mid-60s, that definitely by the mid-70s, when you began to see this pattern of more people having these same kinds of dementia issues. And it wasn't until then that the Alzheimer's Association was established in 1980 with the scientific arm of our mission. So why that is, I don't know. I think probably, you know, certainly in the 50s, 60s, other disease spaces, you know, after we dealt with polio and you know, heart disease, cancer, you know, progression increased dramatically in terms of the improvements of those two diseases. But that's the only reason I can think of, is that it wasn't until the medical community and the healthcare community began to see these common traits in individuals with dementia or Alzheimer's. But much like you, I had a great grandmother who died in 1980, and we used to call it senility, even in 1980. So I had never heard the word Alzheimer's disease at that time.
I'd just like to thank all of you, and especially the Alzheimer's Association, but all of you who are working with and supporting it. It is really difficult until a loved one is diagnosed to realize quite what a horrible disease it is, and one feels so helpless. The support groups that are available around associated with the Alzheimer's Association have been terrific for my family. The roadmap is, as you said, a terrific resource, and to the congressional representatives, staff, we're so grateful for the funding, because that's ultimately what will help bring this horrible thing to an end. Thank you.
I would second that. Thank you very much for the work that you do. There's an organization called the Women's Alzheimer's Movement that's getting a lot of press right now. And some of the things that they're saying is that 2/3 of persons diagnosed with Alzheimer's are women. It's true. And I know that they also seemingly have some research going on. And so my question is there an intersection of the two sets between research going on in your organization and research going on with the Women's Alzheimer's Movement? Does anybody know?
Well, all eyes are looking to me, so I'll put it in. I'm not familiar with that movement, so I need to look into it. I don't know, Carrie, if that's something you're familiar
It's
with.
Maria Shriver's movement.
Oh, yeah.
Yeah, and that statistic is correct. 2/3 of women, 2/3 of Alzheimer's patients are women, and there is a lot of research being done about why that might be. The gender differences could be biological, it could be lifestyle. You know, historically, women played a different role than men in the household and working and that kind of. So they're looking at this from a lot of different angles in terms of the research. And I know that she's been talking a lot about menopause as being a contributing factor. When I went to the international conference last year, I went to a presentation about women who go through hysterectomies at a younger age are more likely to develop the disease later on. So, and they were saying that estrogen is basically brain food. And when your estrogen levels go down, if you go through menopause naturally, over time, your brain has time to adjust. But that abrupt change can impact someone's ability to adapt. So there's nothing definitive. There's a lot of little studies that are being done and looking at it from all different angles, and we're just learning more and more every day, and I think that's one of the questions we're trying to answer.
Great.
Yeah.
Thank you. It would be great.
Do you have any other questions out there? I have a question. Does everyone floss?
I do.
I know the answer, no.
Well, you know,
Can I
yeah.
make one more?
Sure.
Really quickly. Mr. Wiggis, you said that a funding ask for 2020 for the state legislature was for FTEs to serve to serve AAAs. Is that likely to happen? Do we have any idea? It's a supplemental budget year. I just wondered. Good question.
We certainly hope it'll happen, and we will be providing good information to our advocates who visit with their members of Congress on February 18th. Certainly my expert public policy leader, Peter Newbold, also believes that it's likely to happen, and that's certainly what we'll push for. I think we've got probably a stronger case for support, why it's needed, and from the AAAs, and many of them will be with us advocating as well. So,
do you have a sense of which area agencies are kind of specific focus for those initial 4 positions?
we don't. We would certainly advocate that we try and have a variety of demographics. Perhaps one area agency that's more rural, one that's more urban, definitely at least one on either side of the state.
Well, it's also likely to be a competitive bid process.
Got it.
So the area agencies on each would have to propose what they would do, and then it would be competitively selected.
Right.
That way.
And I would like to say with regard to the funding hopes, I think we have a better position than we've ever been in because we achieved 2 years of funding actually in a row if you count the original part-time positions that we got funding for 2 years ago. But also because we're able now to really talk about and demonstrate all of the things that DAC has accomplished to this point, most of it without any financial help and mostly done by volunteers. So I think the legislature is, they're listening better to us, I think. And Peter would be a better person to talk to that point, but I think they're listening to us better, and I think we've developed a track record that has kind of gotten their attention, and at least some of the hearings that I've testified at, it's been very well received.
Well, again, thank you.
Can I mention something? What we didn't talk about today that was well covered in another town hall meeting, and that's around the cost of long-term care. And for those of you, I'm sure everybody's aware, well, I don't know if you're aware or not, but Medicare does not pay for long-term care. Medicare pays for hospitalization, physician visits, and short-term home health. So short-term meaning after like a stroke or you have a hospitalization, you need some follow-up care. Medicare does not pay for ongoing, what we call custodial care. And unfortunately that coverage falls to the Medicaid program, and Medicaid is based on income. So you have to be a relatively low income in order to qualify for Medicaid. So otherwise, if you are not low income and you're not extremely wealthy, you're out of luck in terms of how do you pay for long-term care. So the state of Washington passed a bill in the last session called the Long-Term Care Trust Act. Now, I don't have all the specifics on how it actually works, but basically it's a payroll tax. I don't remember the percentage, maybe Action Peter might know more details here. There's a small percentage that people who are working pay in a payroll tax that goes into a trust fund, and there is, at some later date, after you're vested in the system and you have a need, you could draw down some money. I think it's up to 30,000 or something a year.
32.5.
32.5, is that somebody said? Roxanne? Okay. So, which really, I mean, it's not a huge amount of money, but it's been shown in other studies that that amount of money is kind of, can keep a family going for a number of years, especially in the early stages of the disease. And you probably also know that oftentimes caregivers have to quit their jobs in order to provide caregiving because
We have congressional teams for all 100 senators and 435 members of Congress, including the dozen or so here in our Washington State chapter. You can go to Legislative Day in Olympia, which is on February 18th. And again, you can consider joining the Alzheimer's Impact Movement for a donation as low as $20. So, thank you for your being here, for your attention, for your help, your hope, raise your voice as an advocate for the Alzheimer's Association and issues with Alzheimer's disease and dementia. Our information is here, our Washington State chapter serving Washington and Northern Idaho. Our 24/7 helpline number during the business day reaches our offices in your locale. After business hours, it reaches our help contact center in our home office in Chicago, staffed 24/7 by trained clinical social workers and psychologists, 1-800-272-3900, and www.alzwa.org, alzwa.org. That's our website where you can find us. Thank you very much.
As far as the websites and other things, I think there's a handout you could get, and it's got all that information on it. Hopefully everyone can get something like this. It's up there. All right. So now, thank you so much, Jim. That's a lot of information. Let's get to the panelists. Have them come to the front while I introduce them. Maureen Linehan worked for over 30 years in the aging and disabilities field, including serving as the director of the Seattle-King County Aging and Disability Services, the local area agency on aging, before her recent retirement. She's been a member of the statewide Dementia Action Collaborative since its 2014 inception and is currently chairing its long-term supports and services subcommittee. Maureen serves on the board of the Alzheimer's Association Washington State Chapter, is board co-chair of Generations Aging with Pride, an organization focusing on empowering older LGBTQ individuals to age with grace and dignity, and serves as the Alzheimer's State Champion to Representative Eric Pettigrew. Both of Maureen's parents, now deceased, were diagnosed with Alzheimer's disease. As an advocate, Maureen passionately works to combat the stigma associated with the disease and to increase awareness of supports available to caregivers. Dr. Cheryl Townsend Winter holds a doctorate in dental surgery, as well as, yeah, you get that all the
It's
time.
even worse, I was a gum surgeon.
As well as, but thank you for your good work. As well as a Master's of Business Administration with UW's Foster School of Business, she recently completed a 30-year career in the practice of periodontics. And she reminds people to brush and floss. She's an affiliate associate professor at the University of Washington Department of Periodontics. Cheryl is the author of the 2014 book, The Aging Gracefully Pathway, a toolkit for the journey. She was appointed by Governor Inslee as a member of the State Council on Aging and became its chair. She served as the council representative of the Alzheimer's Disease Working Group, which wrote the state plan. For the implementation of the state plan, she is chair of the Dementia Action Collaborative Subcommittee on Public Awareness and Community Readiness. Dr. Seema Abbasi was born in Pakistan, and after completing medical school there, she moved to Houston in 1990 to pursue training in pediatrics at the University of Texas. She did a fellowship in pediatric infectious diseases at the University of Tennessee and has now been practicing pediatrics for over 20 years. Seema moved to Seattle about 2 years ago with her husband, who's a physician at the VA hospital, and her son, who is now a high school senior. Where is he a high school senior?
Roosevelt.
Roosevelt, go Rough Riders.
Yeah.
My kids went to Ingram, go Rams. She serves as the Alzheimer's congressional team that works with the office of Senator Maria Cantwell. Her motivation to get involved with the Alzheimer's impact movement is more personal than professional. It's a story we keep hearing, right? As a primary caregiver for her father, who passed away in 2016 after a long and difficult 7-year path with dementia, Seema experienced firsthand the devastating toll of this disease on patients and their families. So let's begin with Maureen Linehan.
Then we have a microphone.
Okay.
Hi, good afternoon.
Hi.
So what I'd like to do today is highlight some of the work of the Dementia Action Collaborative as it relates to how Alzheimer's disease impacts communities of color. And I'm particularly excited about that for the upcoming year because we're really upping our efforts in understanding those impacts and how the Dementia Action Collaborative can intervene or create messaging to be impactful in that area. So starting out with just a couple of data points, just to point out that there are some pretty significant health disparities in the prevalence of Alzheimer's disease for certain communities of color. African Americans are 2 times more likely, and the Latinos are 1.5 times more likely to have Alzheimer's disease or other dementias compared with white adults. A small study showed that 1 in 3 American Indians over the age 65 have been diagnosed with dementia. But much more study is needed here because, again, that was a small study and it's not well known what the prevalence is in the Native American population. The prevalence of dementia among Asians is also not well understood. Data for that population is often not broken into different subpopulations or subgroups. And sometimes an overall composite number for the Asian population in general is used, which could be extremely misleading because people have the stereotype, and it's shown in some of the data that Asian Americans might be healthier and have less of a risk, but in fact, when you look at different subpopulations, the risk varies quite dramatically. For example, Vietnamese Americans might have a higher risk, Pacific Islanders. So anyway, there's more study needed there, or a better way of reporting the data, because again, you can't just present composite data for that whole population group. Other information, the LGBTQ population is, study is happening right now to understand the impacts on LGBT people. We actually have the foremost researcher for LGBT aging at the University of Washington, Dr. Karen Fredrickson-Golson, and she has I think it's a 20 years now longitudinal study of LGBT individuals, and then understanding, which has allowed her to present a lot of data and reports around the aging impacts for LGBT individuals. And she hasn't presented this data yet, but she's going to be working on how dementia plays out, the prevalence with LGBT people. There's some speculation that LGBT people, older people, might be at higher risk because of things like stress and trauma in your life experiences, and also, especially for gay men, have a much higher level of social isolation than the general population. And when you think about, for that community, your peer group is your caregiver group. And many people may not be still close with their families, or families may be far away. And in terms of caregiving, and just your support group is typically your peer group. And if your peer members are aging at the same time that you're aging, you may not, that social support can erode. And so again, there's a higher risk for social isolation for some segments of the LGBT community. Other considerations are I missed this. The disparate health impacts also play out in that African Americans and Latinos are typically diagnosed much later in their disease process, and so thereby losing any opportunity to plan financially or legally for the impacts of Alzheimer's disease. And then African Americans are 40% less likely to receive anti-dementia medication compared to the white population. So again, for the Dementia Action Collaborative, other really important things to understand is, the whys behind these disparate numbers. It's thought that the underlying risk health factors, such as the hypertension, diabetes, lack of exercise, may play out differently in different ethnic groups. And so from our point of view, it's very important to understand those underlying factors, which also include cultural stigma about how Alzheimer's disease is perceived within your cultural community, and that some communities have a much higher stigma. I mean, we all have stigma about aging, we all have stigma about Alzheimer's disease, but some communities have very, very significant stigma, which may then either allow them to more so even mask the symptoms or not seek medical care or not do health care related planning. And then also other considerations on how Alzheimer's disease and access to services plays out is how the family member, who might be a caregiver, might be multiple members, how they view their role as a caregiver. They may not identify as a caregiver. They may not want to access the services that exist, things like respite, because it would be seen as letting your loved one down if you were to allow somebody else to come in the home, even though you might desperately need respite for a break, a couple hours, once or twice a week. It's, let's say, it might be more significant for some cultural groups about taboos around having people come into the home, and that your person, you as a caregiver, you as a family member, and that role as a caregiver, that's not something you could do. So as I mentioned, the Dementia Action Collaborative, we've been focused on understanding these differences and understanding also, as Jim mentioned, that there are health risks that are modifiable, and research is showing or speculating or stating that up to 35% of your risk for Alzheimer's disease can be modified based on these lifestyle changes. So again, if you can manage your hypertension, manage your weight, exercise, that can have significant impacts on either slowing down or maybe being diagnosed at a later age or not being diagnosed at all. Okay, so then the highlights of what we've already accomplished in this area. Jim mentioned the roadmap, and the roadmap has just been translated into Spanish. And it is hot off the press, and it is available in Spanish. And we worked on an effort called Memory Sunday, which is an effort with local African American churches to raise awareness about dementia, including understanding again what those modifiable risk factors are. And so these would actually be with pastors in African American churches who, during their sermon time, would talk about the risk factors and various things related to increasing awareness about Alzheimer's disease, the warning signs, for example. And then we've also supported a University of Washington study to understand effective public health messaging for the Asian population. So now, again, as I mentioned when I started, the exciting work of 2020 is really now to look at how these health disparities, how we might be able to impact the health disparities through all the committees of the Dementia Action Collaborative, and how we are looking at, I have the list of, like, public awareness, for example, and influence of public, that's Cheryl's committee, right? The Public Awareness Committee. So how their public messaging needs to take into account that not all communities, you can't do the same kind of messaging for all communities that is important to take into account things that I've already talked about, and craft your messages to a specific community that you're trying to reach. But once again, it's focused on reducing stigma, improving brain health, improving brain health understanding and and the importance of getting an early diagnosis. And then also the committee that we're working on with the health disparities, we're looking at developing fact sheets, dementia disparity fact sheets for each population group, which again is the importance of understanding how we're not a monolith community, we're not homogeneous, and the importance of understanding how this plays, the prevalence of dementia and Alzheimer's plays out in different communities. I think I'll stop there and pass it on to Cheryl.
Thank you, Maureen. So we don't get too tangled up when we pass on next time. Okay. Well, thank you for having me here today, and thank you all for attending to listen to what we have to say. I have a few things I'd like to highlight from Jim's presentation. One, that research aspect is extremely important. As Jim said, we need financial support to deal with this very significant national public health problem. And I don't think it can be said enough that this disease is severely underdiagnosed, and there's a huge need for post-diagnosis support for this disease. I also think it's really important that we recognize and move forward helping those with younger onset dementia. I think it's a bigger problem than we thought it was, and I think the fact that we're starting to recognize it and do something about it is really important. And then looking at best practices for care and support, as Jim said, is also extremely important, along with the grants that are needed, the dollars that are needed to emphasize early diagnosis and avoid hospitalization. And I'm glad you're back, Jim, because I wanted to share something with you. Gum disease has also been associated with dementia. It's definitely associated with cardiovascular disease, and it's a proven association with diabetes. So make sure you floss. I had to get it in, I had to do it. So it's 30 years. Okay, and then Peter asked me, as he does every year, to identify things, state plan recommendations that I think would be helpful to implement. And I tell Peter every year, all of them, they're all important. So it's extremely hard to have to choose. But that said, I do want to kind of highlight that, as Jim said, 2019 was a stellar year for the DAC. Our efforts to implement the state dementia plan, because of the legislature funding of those 3 initiatives, is going to definitely be helpful in moving this forward. And I just want to review, this is a little bit redundant because Jim touched on them, but I just want to review those 3 things a little bit. The first initiative was the University of Washington Neurology Department received funds to create the telemedicine program that Jim mentioned, to disseminate dementia best care practices to primary care providers. UW is laying the foundation for implementation of the Project ECHO Dementia to train primary care practitioners. Planning and preparation underway includes recruitment and hiring of the UW ECHO project coordinator, and I think they're starting to interview or just getting ready to start. Locating a space, which they've done, planning for training and use of the telemedicine platform and technology, gathering their multidisciplinary clinical team to create curriculum, and making outreach contacts to primary care systems and providers. The second initiative, the Department of Health received funds to investigate existing evidence-based messages and public awareness campaign strategies, and to develop, place, and evaluate messages through a short-term digital awareness campaign in at least 2, but no more than 4 targeted areas of our state. DOH is working on research and development, including a contracted literature review to investigate these existing evidence-based strategies and messages and public awareness campaign strategies and messages, and is gathering a DAC project team to advise and inform the campaign. And I'm really excited about this one in particular because one of the chief individuals helping spearhead this is the staff person to my subcommittee, Marcy. So we get to keep really abreast of this one, and we're really excited about it. The third initiative, DSHS and the Aging and Long-Term Support Administration, ALTSA, received funds to contract with an organization to provide educational materials, legal services, and attorney training to support persons with dementia. So ALTSA's been working with the DAC Legal Project team, which has been in existence already for almost 3 years, to develop content for a dementia legal toolkit, which is now completed. Woo-hoo! And they have published a request for information in July to determine interest from organizations, and is developing a full request for proposals to secure a contractor to pilot the provision of attorney training and the pro bono services. Some other DAC accomplishments that I think are extremely valuable in moving this important work forward include the translation of the Dementia Roadmap, which Maureen mentioned. Also, that we have achieved approval for the cognitive decline module inclusion into the Behavioral Risk Factor Surveillance Survey, also known as BRFIS, for 2020. Final enhancements were just recently completed for the CLC webpage that Jim mentioned and showed on the slide by our website project team, and we've begun dissemination of that site. The URL for that site, which is, as Jim showed, memorylossinfowa.org. This webpage is a one-stop shop site for information, resources, and local services related to dementia. The Let's Talk Dementia video set is now completed and available. You can link to the videos if you want to through the Dementia Action Collaborative webpage, which you can Google, and the Washington State DSHS YouTube channel. I'm also really excited about working with DOH. In addition to the funded project, the initiative that we talked about earlier, we're making other links with that department, including they're now offering a webpage of their own with links and information on brain health and dementia. And that's really important to me because I've always felt that public health should and would and needs to play a big role in this project about dementia. A critical strategy for improving care for people with dementia in the state was to identify a set of standards of care for dementia, which Dr. Chris Rhodes did with his health subcommittee. And he was working with the BRE Collaborative to develop those evidence-based recommendations, which Jim mentioned. Unfortunately, the BRE itself does not have funding or capacity to do much regarding dissemination. So I absolutely think we need to really find ways to disseminate that information to primary care providers across our state, because I think the impact on that would be just tremendous. While there's not yet a way to prevent dementia, there's emerging evidence of a link between heart health and brain health, which Jim mentioned a couple of times. And prevention and early diagnosis and treatment have been repeatedly shown to significantly reduce the costs associated with healthcare for patients with dementia. The legislative funding this year supported public awareness on those evidence-based connections, but at the same time we are recognizing, and Maureen talked about this fairly extensively, that there are existing health disparities. So I think it's also important for the DAC to view our work through that lens of health disparities as we go forward. The DAC developed community healthcare worker training modules, which there were none before, which is kind of interesting that it took this long. And I would really like to see us expand this. I know we've reached at least 40 care providers already, but I think this is another one that would be a really excellent return on investment. And then last but not least, the Dementia Friendly Communities Project team has produced and is continuing to produce numerous valuable accomplishments. They're a busy, busy group. They recently completed a Dementia Friends program launch in our state, along with an evaluation of that program, and their findings suggest that the Dementia Friends program positively affects attitudes towards people with dementia and may be a promising avenue to combat stigma and raise awareness. This project team will be using that Dementia Friends model to implement this year's top priority recommendation from the entire DAC for my subcommittee, which is to raise awareness of dementia and available resources by engaging public and private champions,
including faith, business community leaders, corporate leaders, nonprofit partners, educators, and health professionals to assist in developing, implementing, and leveraging education and outreach. This project team is also planning a governor's summit on dementia for September of 2020, so keep your eyes and ears open for that. Before I turn the mic over to Seema, I just met Seema today for the first time. I just want to make a statement about, and I know Maureen feels the same way, how proud we are to be associated with the DAC. DAC's an incredibly effective organization, best collaborative I've ever seen. In all my years of professional experience and educational experience, never have I seen a group that's as effective as this one is. And I just stumbled across something that I wanted to share with you. There's a concept called collective impact. It came up at my most recent subcommittee meeting, and what collective impact does is it brings people together in a structured way to achieve social change. And they have a whole bunch of principles of practice that are associated with this. And if I look at the DAC and look at that list, these are the things that we do that work and help us do what we're trying to do. And I think bringing all those things together can really produce, and has produced, extraordinary results. And I think collective impact is one of the avenues that we can use to take us from common goals to uncommon results. Thank you.